Welcome to Almost Here, Round the Corner Future Technology podcast with Richard Jacobs. Future technologies poised to transform our lives for better or worse are the focus of this podcast. Almost here means these technologies are now here and starting to be used, or just around the corner, from Bitcoin to artificial intelligence, 3D printing, blockchain, virtual reality, and more. Hi, this is Richard Jacobs with Future Tech Podcast. My guest today is Francois Binette, Senior Vice President at BioTimeInc. Francois, how are you doing?
Very good.
Yeah, thanks so much for coming. If you would, can you give listeners an idea of what BioTime does and what you do at the company?
Yeah, so generally speaking, I'm head of product development. I'm responsible for all of their research and development activities, as well as project management office and regulatory affairs. So BioTime is a regenerative medicine company. And as such, our mission is really to cure disease and injury and not treat symptoms like pharma and most biotechs are doing. So our therapeutic approach is a little bit different than traditional drug and biotech companies. So we're really trying to restore normal structure and function of most tissues and organs that are affected by either normal aging, like degeneration and diseases, or as a result of injuries.
So, I mean, there's many tissues in the body. What are the top ones that the company's working on? You know, what are your most important projects or your most interesting ones?
Right. So right now we have two programs that are in clinical development. So our focus right now, our main focuses are on ophthalmology and on medical aesthetics from a clinical development perspective. So we have a program in yep.
Oh, I was in medical aesthetics.
Yeah.
Well, I mean, we'll get into that, but go into them in the order you'd like to go into them.
Yeah. So I'll tell you in a minute. So for ophthalmology, as you may know, there's a disease process that's associated with aging that's called macular degeneration. It's the major cause of blindness in the aging population. And what happened is that the cells that are nourishing and maintaining the photoreceptors of the retina, these are the cells that are, the photoreceptors are the cells that are capturing the light and transmitting this information to the brain to produce an image so that you have vision. But the cells that are basically keeping these photoreceptors healthy and happy are called the retinal pigmented epithelial cells. And with aging or with some kind of disease process, they sometimes degenerate, and as a result, they no longer are able to maintain the photoreceptors nice and healthy. And these photoreceptors, as a result, they will degenerate, and basically you lose vision, you become blind. So we have a very exciting product that's basically we have a very robust process of making in our laboratories, making these cells that are called, as I mentioned, retinal pigmented epithelial cells, or RPEs, from pluripotent stem cells, and a product that we call Oprogen. So we're using these cells to really implant these cells in the subretinal space or under the retina, right where these photoreceptors are starting to get damaged, in the hope to restore these cells and maintain photoreceptor health and preventing people from becoming blind or that their vision impairment becomes worse over time. So right now, Oprogen, as we call it, yes, sorry.
Yeah, what's the physical mechanism that helps someone from preventing them from vision loss once you implant these cells?
Yeah. So what happened is as I mentioned, these cells are really there to nourish the photoreceptors. So they're there to maintain their health, right? So as they're disappearing, the photoreceptors are disappearing also as a consequence. So what we're doing is we're implanting nice and healthy retinal pigmented epithelial. So these are really the equivalent of putting nice young cells that are not affected by the underlying cause of the macular degeneration, right? So it's like putting some nice, fresh new cells there. And these cells will engraft and will attach to the subretinal space, right, and spread out, and will become in contact with these photoreceptors and will help maintain and provide their normal health. So we're really replacing the damaged cells as a result of the disease process with nice and fresh, healthy cells. It's really cell replacement therapy. So these cells will come in and replenish the space and maintain these photoreceptors and prevent from further degeneration. Right? So it's really a mechanism of cell replacement therapy.
Very interesting. So what stage are you at? Have you done clinical trials?
Yeah, exactly. So this is an early stage trial, right? So right now we're about in the middle of our phase 1/2 trials, right? So you know that clinical development involves safety trials first, which are called phase 1 trials, and then proof concept, which are phase 2, and then you demonstrate the real clinical benefit in larger phase 3 trial. So our OpRegen trial is in a phase 1/2A. So we're really treating patients right now. We're not treating healthy volunteers as typically people do in phase 1. So we're treating people that are affected by macular degeneration, but they're very late in their disease process, right? So when you start clinical trial in early stage, usually the regulatory agencies are asking you to treat the, very late stage patients such that, in case something goes wrong, that you don't exacerbate or if you don't make things something worse, right? Especially for vision, you can imagine if these people had some vision left and your treatment worsened their state, it wouldn't be a good outcome, right? So these patients are very early, a very late stage. So they're legally blind. So we're not going to affect their vision negatively, even if our therapy would not work. But what we're seeing right now, because we're in the middle of our safety trial, we're just starting now. It's a dose escalation trial, meaning that we treated with very small dose first, right? And we're increasing the therapeutic dose or how many cells we're implanting as we're progressing through our trial. And right now we're starting to dose patients with more clinically relevant doses, like higher dose that we think might be useful for the patients. So we're seeing right now that the therapy appears to be well tolerated, and what's exciting and what we find exciting is that the cells appear to be engrafting, and that is, we see that structurally the retina appears to be behaving the way we're hoping that it will, right? So we can look by various imaging techniques, where the cells are, where we implanted them, and how they behave. It looks like they're doing what they're supposed to do, right? They're spreading out and they're making new contacts with the photoreceptors. So we don't know whether this will improve patients' vision yet. As I said, it's too early stage, but we're excited about at least structurally, the product appears to be doing what we're hoping that it will do. So that's very early, and we're moving. Like I said, we're about midway through our trial. Later this year, we're going to start moving into even a higher dose of cells. So really treating patients that with a number of cells that we think will effectively repopulate the disease area. In other words, right? And then we'll start treating at the end of this early stage trial. The last cohort of patients we'll treat are patients that are with less severe blindness, right? So people that have still a little bit of vision. So I think we'll be in a better position to see, no pun intended, whether these patients actually we can modify the disease process, either slow down the progress of the disease, so prevent patients from becoming blind totally, or even hopefully rescuing some of their vision.
Yeah, that's what I was going to ask you. Are you hoping for their vision to be completely restored, or just slow it? But you said you're not sure. You're hoping for one or more of those things. Right.
So initially, what we're hoping with this kind of product, we're hoping to slow the disease process or stop it, right? So this is, in other words, as part of the disease, the natural history of progression of macular degeneration, I was saying, in the late stage of the disease, those photoreceptors are so damaged, they're completely gone, right? So you cannot recover vision when the photoreceptors are completely gone. But hopefully we can recover some vision when they're just detached from the disease or damaged retinal pigment epithelial cells at the bottom. Those are the cells that we're replacing. And they're still alive, but not functioning right? So hopefully that could provide the basis for vision recovery. But the idea is that if we can treat patients early enough, right, and that's where we're going with this, as you can imagine, if we can treat patients early enough when they're not blind, right, when you can diagnose that, yes, you have macular degeneration, if you don't do anything, you're going to progress to blindness. But hopefully we can treat patients early enough such that by replacing the damaged tissue, the damaged cells, we will save their vision, right? And they will not progress to becoming blind. So that's kind of the first stage. Yeah.
Yeah, if you can, just tell me more about at what ages does the disease start and how long does it take until you go blind on average, and any other factors, more men than women, different ethnicities. Just tell me more about the disease itself as well.
Right. So, macular degeneration is very prevalent, right? It's one of these diseases that affects in the U.S., close to 10 million people. People are in the later stage of, the disease and what we call geographic atrophy, which is really like damaged photoreceptors, if you will. There are 2 million people that are blind or close to being blind in the U.S. and it's extremely prevalent. It's normally occurring in older patient population. Typically in your 50s and 60s, people are starting to look at these. I'm in the 50s right now myself, and each time I have an eye exam, people, my optometrist looks for signs of this disease process, right? Mm-hmm. And that's there are two forms of AMD or age-related macular degeneration. There's a dry form, which is the most prevalent form, which is the one that we're targeting with our therapy. And there's no treatment right now for this type of problem. There's another form which is called wet AMD, which is the result of a vascular problem in the eye, in the retina. You have like these little blood vessels that are growing and bursting and are damaging your retina. That's called wet AMD. It's often also a consequence of dry AMD, but it's a different form of macular degeneration that is actually pretty well managed with drugs that are already on the market. A couple of drugs that are available that are there to really slow down these blood vessels that are becoming overactive or growing too fast in your retina and are damaging your retina. So there are a couple of drugs, but it's really a smaller fraction of the overall macular degeneration problem.
For your treatment, is it a one-time treatment to input these cells, or does it have to be done multiple times?
Yeah, absolutely. So, that's the beauty of regenerative medicine, right? I mean, like I said early, regenerative medicine aims at curing patients, not treating patients. And we're doing that by providing the cells that are either replacing the cells that are damaged or diseased, right, or degenerated. So the goal is to have a single treatment that will be done by a retinal surgeon and will solve the problem. In the same therapeutic areas, we have additional, much earlier stage research and development effort that we announced last week that we are developing full thickness retina. So this is for people with different types of vision loss or very late stage vision loss where people are completely blind, in other words. Right. And this is going to be a much more complex product, but will hopefully aim at really restoring vision and people who are completely blind, because now instead of having just these cells that are providing maintaining the photoreceptors health, now we can generate in our laboratory not only these cells, but also the photoreceptors and also the other nerve cells that are making up the three-dimensional structure of the retina, and implant all of this structure in blind people. So people with completely lost vision could potentially have a restored vision. So that's very exciting, but it's very, very early stage and very, not really ready for clinical trial. But we're putting a lot of emphasis on these programs because, like I said before, there's really no therapeutic solution, right, for these people.
Yeah.
Once you have lost damage, like I said, the only way to cure people with lost tissues to, add these tissues or cells back to them, right?
What are the, out of curiosity, what are the stages of blindness? Is there a point where you can't identify objects, but you can still see light and dark? And I guess there's a stage where you can't even see light and dark? What are the...
Yeah, absolutely.
So,
I'm not an ophthalmologist, but I'll tell you what I know, right? There are different diseases that are affecting vision, right? And some of them are genetic, in nature. And in other words, inherited because of bad genes or whatnot, so familial diseases. And some of them is just aging, right? And they affect different cell compartment of your retina, right? So, for example, macular degeneration is a disease that affects the central vision, which means that it's the central vision is your most accurate. It's where you read, it's where you recognize faces. It's the very center of your retina. It's extremely sensitive area, but this is the most important one, right? Because that allows you to have the actual functionality of being able to read, recognize faces, and everything else. And when you have macular degeneration, usually the process starts in that area. So as a result, sometimes you have this vision where you actually lose. It's called tunnel vision. You have a dark spot right in the middle of where you're trying to look, but you still have what we call peripheral vision. So it's not as useful to have peripheral vision as you can imagine. And that's like I said, that's the most prevalent way of losing your eyesight. So sometimes you'll see people on the street and they kind of looking sideways. I don't know if you ever noticed that, but you'll see people that they're walking or reading or looking at their phone, but they're kind of looking sideways. It looks like they're not looking at the phone, but they're using their peripheral vision to read or figure out where they are. So there's another disease which is called Retinitis Pigmentosa, which is different because now this affects the peripheral vision instead. So it's the photoreceptors now that are being damaged a little bit all over the place, and it can affect just about any part of your retina. That's not as prevalent as macular degeneration, but it's more severe because it affects the photoreceptors right away. So with our Oprogen, product right now, we would not be able to address this patient population, but with our, engineered 3D full thickness retina, we could. So these people will lose, photoreceptors, and it's a really aggressive type of degeneration, but it doesn't affect necessarily the central vision. So oftentimes it's the opposite. You lose the peripheral vision, but not the central one. So there's, obviously there's, like I said, there are many, many different causes of blindness, but typically you lose sight, when the photoreceptors are being damaged, right? So these are like I said, the little receptor of light that will capture either color vision or black and white vision that are, that are going bad for many reasons. That's the typical way of losing your eyesight.
Okay. All right. To shift gears a little bit, you talked about medical aesthetics. What is that?
Yeah. Medical aesthetic is, is an area where it's a little bit different. Obviously, it's using instead of using our progenitor stem cell platform, it's using the other platform that we have in the company. So we have pluripotent stem cells, but we also have a Biomaterial Delivery platform. And that's really important because, most of the time when you want to engraft cells, in order for cells to engraft effectively and remain on site and also survive for the long term, they need to have a delivery system, right? They need to have a scaffold where they can attach and it can be retained in place. And then there's, once they're implanted, you need to have a very rapid vascularization of the graft such that the cells are nourished and they can, exchange and get rid of their metabolite as part of their natural biology, right? So having a delivery system is very important. So we have this delivery system, which is a biomaterial that's made of naturally occurring biomaterials in your body. It's made of collagen and long sugar chain that are present in everybody's tissue. It's some of these component or actually making the structure or the matrix of your tissue, right? It's what's keeping your cells together in a tissue. So we have these highly purified components that are based on collagen and hyaluronic acid that we can use to deliver cells very effectively and maintain them on site, like I said, right, for engraftment. So the second platform or the second therapeutic area is called medical aesthetic, as you said, and is for people who have basically lost in subcutaneous tissue that result, for example, our first clinical trial is called Renivia. And what we're doing is we're in people that, in HIV patients, there's about a quarter to a third of the patients that are suffering from severe fat loss in the face, right? So this is an outcome of some of the medication that were very popular in the early 90s and are affecting the biology of the subcutaneous tissue. And as a result, they have these facial wasting disease. Basically, the fat, the subcutaneous fat in their face is disappearing. So you have these very weird skeletal faces, and it's not related to what they eat or how fat or they are. It's really, like I said, an outcome of the toxicity of some of the drugs that they took earlier. So these patients, as you can imagine, they have a need for restoring the normal contour of their face. It's really a medical need. It's not just, we're saying it's cosmetic or aesthetic, but it's a real unmet need, as you can imagine. People with severe lipoatrophy, they don't look normal, right? And they look diseased. So they want to restore the volume and the natural contour and feeling of their face. And also, it's an outcome. Also, if you can imagine, we're working with the Department of Defense, for example, where a soldier or a combat injury, when they have blast injury in the face, you can imagine they have severe trauma to their body, including their face, right? And sometimes it results in severe loss of tissue, right? A blast injury can basically blow apart part of your face. And although you can reconstruct the bone underneath with scaffold or prosthetic, the subcutaneous tissue is not restored, right? Because it's a living thing. So there's a lot of soldiers that come back from injuries and they want to have their again the normal contour of their face restored. So what we're doing is people in the past, what they've done, the standard of care, so to speak, is people take what they call a procedure called fat grafting. Is they take a piece of fat from your belly or somewhere else and they transplant it to the subcutaneous place where you have a big defect, like a big volume defect. The problem is when you do that, these types of grafts are not very stable and they tend to break up over time, and the effect is temporary. It just only lasts a few months. So what we're doing is we're doing the following. We're using our Renivia, which is our biomaterials. What we're doing is that we're combining our biomaterials with cells that are isolated from fat of the same person, right? The donor. So you have an HIV patient or some patient that suffered a traumatic blast injury of their face. So they have usually these people have fat in their belly somewhere, right? So we can suction through a standard liposuction. Can suction some of this fat tissue, and what we do is we can isolate the cells that are the progenitor cells of this fat tissue, and enrich these cells and combine Renivia biomaterials system. Renivia is a hydrogel. So what we do is we combine these cells that have been isolated at the point of care, and all the surgeon is doing that, and then you can have now an implant instead of fat. Now it's a biomaterial that contains the cells that normally are the progenitors or the precursor of fat and other subcutaneous structures in a very much enriched graft. And the idea is to implant that in the subcutaneous space, right? And then hopefully this tissue will be much more predictable at restoring the volume and the contour and the physical tactile and appearance of the skin. So that's an ongoing clinical trial that right now that we have in Europe using, with HIV patient right now, and we're in a very late stage. We're in a pivotal stage with this trial. So we're expecting top line data in the middle of this year, sometimes in June. Because we've conducted already a small pilot case or phase 1, if you will. It's a little bit different because in this case, it's a medical device. So it's a pilot and pivotal stage. So right now we're in the late stage. We're in pivotal stage, and we finish enrollment of this trial. And we did a few practice patients, before we started this trial. It's typically done for surgical procedures. They're kind of complex, right? It's not like a drug where you just prescribe a pill, for example, right? There's when you do what I described, doing the liposuction, isolating the cells and combining with our hydrogel system, and then reimplanting this hydrogel through a syringe in the face of people to restore their subcutaneous volume. You can imagine it's kind of a complex procedure. So we did a trial run on a few patients, and they're not part of the trial itself, but we follow them up, right? So it's kind of like an open label trial, if you will. So the 9 patients that we've done a long time ago, about over a year ago, they seem to be doing well, right? So that's why we're kind of optimistic.
What does that mean? What does that mean, doing well?
Doing well in the sense that what we're looking for this particular procedure is we're hoping to have long-term volume restoration, right? So the outcome is based on a measuring of volume restoration for these patients. Like if you can imagine these dermal filler, right, to treat wrinkles, for example. Right, that's what they're measuring, right? They're measuring a volume, or we're looking. We have
Is that what you mean, fall apart? Let's say you'd fill someone's cheeks out so they've got nice round cheeks.
Right.
But over time, fall apart means their cheeks would start to sink in again, and you're hoping that they stay looking good for a year or however long.
Yeah, absolutely. So that's the idea, right? So this tissue, when you implant normal fat, typically the fat breaks down and eventually gets to resorb naturally, right? And so like you're saying, the volume is lost, right? So the cheek will sink back down, as you said. So we did our ongoing trial is using a relatively small small volume of implant. It's about 5 cc. And we're hoping that this 5 cc will give us a reading to look at larger volume defects. So we'll follow up. Although this trial will allow us to gain hopefully registration in Europe through a CE mark. What we're hoping is that we'll be able to treat patients with much larger volume deficit. For people, like I said, that have large traumatic defect or other facial fat wasting diseases.
What's a quick example of a very large problem? Would it be a leg losing all the fat and all the muscle, or what are a couple examples of a serious problem that really can't be solved well right now?
Right. Sorry. There's multiple ones. Whenever you have trauma or a surgical procedure, right? Again, this particular technology is right now is really limited to subcutaneous fat, right? So that's why right now the facial fat loss is where we're most concentrated on. Like I said, like HIV or trauma or other fat wasting diseases, you result in this or aging, right? As you're aging, that's also a typical aging process. you lose fat in your face, right? And some people like to have a more youthful appearance by restoring the volume in your face, which changes dramatically. And that's normal as part of the aging. But there are other procedures that also will impact the cosmetic appearance of your body, right? Like breast implant, for example. That there's fat. The breast has a lot of fat, and fat is an inherent part of the the cosmetic appearance as well as the tactile appearance of breast. And when you do implant that are made of silicone or synthetic material or saline, whatever, plastic, right? And you don't have that fat that's provided typically with normal breasts. So we're hoping that perhaps we can use the same approach to fill in, so to speak, those divots and those tissue defects, as well as I said, traumatic injuries, right? You mentioned subcutaneous loss, whether it's muscle or other tissues. We cannot address that using this particular approach because what this restores is really the underlying fat. But as when you have surgical procedures, whatever they are, or an injury or a burn, severe burn, for example, you often can restore the skin or the muscle, but you lose the normal look, right? Of because you need to have that fat, to provide the elasticity and the cosmetic appearance, as well as the like I said, the cosmetic and the feel of normal skin. So yeah.
Okay. Well, very good. I guess last question or so is, where do individuals or companies connect with you and learn more about BioTime and maybe show interest in some kind of interaction or business relationship?
Yeah, so we have our website. People can definitely reach out to us through the website. We have a PR firm that works with us as well, and we can connect through our PR, investor relations, and public relations. So happy to provide that as well. But we have a very strong presence in multiple meetings and scientific meetings and medical congresses. I spoke to you about two of our most advanced program, which are ophthalmology and medical aesthetic, but we're also involved in other therapeutic areas. In orthopedics, for example, we have a program in bone repair and regeneration. We're looking at multiple delivery therapies as well, whether it's stroke or cancer or osteoarthritis as well. So we're looking at these are projects are a much earlier stage, but definitely have interest in those therapeutic areas, and that's also described in our pipeline and our website. Okay. And you'll see our management team is there, and there's a way of connecting with us definitely through our website.
Well, that's great. Well, Francois, thank you for coming on the podcast. And I'm glad that you're working on real important issues. Fighting macular degeneration and helping people that have problems with fat on their face or various areas because of catastrophic problems or because of the wish to look better. So thanks again for coming on the podcast. I appreciate it.
Yeah, happy to do so. Thank you very much for the opportunity.
You have been listening to Almost Here, Around the Corner Future Technology podcast with Richard Jacobs. Subscribe to this podcast, post a review to discover more future technologies that are poised to transform our lives for better or worse, such as Bitcoin, artificial intelligence, 3D printing, blockchain, virtual reality, and more.